Hi everyone, welcome to episode 6 of a comprehensive review of dermatopathology. Today we're going to be discussing alopecia and follicular disorders. So this is a difficult topic for a lot of people, but we're going to start a little bit with some basic anatomy. I'm not going to do it very detailed, but what's more just kind of clinically relevant for you guys. And then just an introduction on how to approach alopecias and other follicular things and how to understand them in the clinical context and why we use certain terminology. So as a review, we kind of covered this in the normal skin section, but let's look at a biopsy of the scalp. So these are terminal hairs. Terminal hairs should be down to the fat. You see the matrical portion of these follicles are down in the fat. And these are cut slightly slanted, but then you can see them go up and open into the epidermis. So the infundibulum is the portion of the hair follicle where the epithelium is the same as the epithelium in the epidermis. So when you have an infundibular cyst, you'll have a granular layer and basket weave keratin similar to how you have it in the epidermis. It extends down to about the point where the sebaceous glands insert into the follicle. So this upper portion is the infundibulum. From about the area where the sebaceous lobules attach to approximately where the piloerector muscle attaches to the follicle, that area is called the isthmus. And the epithelial cells there are a little bit plumper and a little bit paler, and you start to lose that granular layer compared to the infundibular epithelium. In this area, approximately where the piloerector muscle inserts into the follicle is where the follicular bulge is. And remember, in the bulge is where the stem cells of the follicle are. Then beneath that, the epithelial cells have become paler, and they become so pale that they become white. And then they palisade on the edges like these piano keys. And this is the tricholemal portion of the follicle, or also it's been called the suprabulbar area because the bulb is at the bottom. So it's the part above the bulb. And this is where you'll see areas like, outer inner root sheath, etc. But we're not going to review all that because it's not so relevant for you learning how to interpret hair biopsies. And I don't want to lose your attention. So, and then below this tricholemal portion is where we have the bulb, okay? Here's another picture where you can see the follicle. So once you have the sebaceous lobules, you're sort of in this isthmus area. Above that, you're in the infundibular area, and then beneath that, it transitions to these very, very pale glycogen-filled cells, which is the tricholemal portion. And then you have the bulb. And the bulb, normally in anagen, is nice and plump and fat like this. And then you'll see as you go into catagen, basically what's happening to the follicle is shriveling up. So it's a little wavy and shriveled, and it's traveling up and down this elevator that I'll show you. Okay, so up close, just to drive the point home, this is your infundibular epithelium. It looks just like the epidermis of your skin. Okay, basal layer, spinous layer, granular layer, keratin. Traveling down to the isthmus, you can see that your cells are a little bit paler and a little plumper than the infundibular cells. Heading down towards the tricholemal zone, they're starting to get even paler. You see you've completely lost the granular layer at this point. Now into the very, very pale area, you see where these cells are, the basal layer here looks kind of like piano keys, these white cells lining up. And then here's a hair shaft. Here is your bulb. This is the papilla of the bulb, and these are the matrical cells. Okay, this is where the pigment is stored, and it gives the pigment to the hair follicle. All right, and then just as a cross-sectional view, when you look at the biopsy horizontally sectioned at approximately the area where the fat meets the dermis, these round cells, these round follicles, these are your anagen follicles. Okay, so in a normal scalp, your ratio of anagen to catagen / telogen is approximately 85% to 15%. I clump catagen and telogen together because catagen really only lasts for a couple weeks before it becomes telogen. So there's sort of an indication of the same phase. Normal terminal hair should extend all the way to the fat, like I said. And then telogen lasts about 3 months as opposed to catagen that lasts 2 weeks, which makes sense. For example, after a stressful event, we always tell people about 3 to 4 months later, they're going to notice their hair loss because the hair transitions to the catagen phase, and then it takes another 3 months for it to actually fall out. So this is horizontal sectioning of the biopsy. You take the punch biopsy, here's the epidermis and this side's the fat, and you cut it cross-sectionally in the center. And then you take that cut side and you lay both the cut sides down. And then as you're cutting deeper into the block, on one side you're cutting deeper and deeper into the fat, and the other side you're cutting higher and higher into the epidermis. So this is an example of horizontal sectioning. One side will be dermis heading up towards epidermis, and one side should start at the junction of the fat and the dermis and then extend down into the fat. And you can kind of see here that you have a lot less hairs in the fat than above it, suggesting maybe that your hairs are miniaturized. It is really helpful to get horizontal sections because a lot of our non-scarring alopecias are not particularly inflamed, and the only thing that helps us tell what the diagnosis is the ratio of your anagen hairs to your catagen/telogen hairs. So you can see here, first of all, that you have an approximately normal number of hairs. You just kind of look around and you're not missing any sections with hairs in it. You know, different groups of people have different normal numbers. I'm not going to kind of go into that sort of detail here, but overall you have a normal number of hairs. Looking, you see immediately that you have like 3 or 4 or 5 obvious telogen catagen looking hairs, which is an increased ratio compared to the normal numbers of those types of hairs compared to anagen. And so that helps you with a diagnosis. A vertical section will not give you the information of a ratio because you can't tell how many hairs you're looking at. So as a review, these are anagen. These are round and there's no necrotic epithelial cells in the follicle. This is what catagen looks like. The first phase starts with these apoptotic keratinocytes or epithelial cells in the follicle. So as soon as you start seeing that, you're hitting catagen. Then what happens is they start to shrivel and the inner section starts to become flamey looking. So as you get smaller and smaller, you're going to start to see the flame further along into telogen until it's completely like this little squiggly little section inside of this fibrous little column here. This is a full telogen. So this section shows you a section of hair in almost complete telogen. This is what it looks like when you compare it to a vertical section. In a vertical section, now your hairs, instead of being round and plump like we saw earlier, they're all shriveled, right? And when you cut this shrivel horizontally, that's when you see that little squiggly thing. And then this is the little kind of fibrous sheath that the follicle is moving up and down in. And as it shrivels upward, you'll see this little trail, the elevator that it goes up and down, which horizontally we call the little stella. Okay, here is a telogen follicle up close, and you can see, you can get little areas of pigment inside of it. And this is the bulb of a telogen follicle. It starts to get really skinny compared to the fat bulb we see in an anagen hair. This is a picture of the little stella, the little elevator that's it moving up and down. And as that hair goes off into telogen, it ends up close to that stem cell region in the bulge, which feeds it more stem cells, and then the hair will move back down the elevator and become another anagen hair. This is an example of miniaturization. As you get towards the top, all of the hair follicles narrow, so it can be hard to tell which one's a miniaturized hair versus a normal hair. But one way to tell is the hair shaft diameter. Look how thick this hair shaft is versus this little hair shaft. This is a miniaturized hair. You can see miniaturized hairs in things like androgenetic alopecia, but also in chronic telogen effluvium and chronic alopecia areata, you will eventually miniaturize a lot of your hairs as well. All right, so we'll start with non-scarring alopecia. In non-scarring alopecias, you're going to see an increase in this catagen-telogen ratio to anagen. These are the conditions we think of mostly, right? Androgenetic alopecia, telogen effluvium, alopecia areata, and trichotillomania. And a lot of the ways that we distinguish between these, if we don't have all the features, is with the ratio. So, androgenetic alopecia, what you're really going to see is a significantly increased number of miniaturized hairs. So back to this specimen that we saw earlier, here in the fat we see almost no hair follicles compared to a normal number of hair follicles in this section. And so what does that tell you? Well, it tells you that your hairs are small because they're not reaching all the way down into the fat anymore. And as you go in closer to the top, you may count that you have more miniaturized hairs than normal. Of course, if this is an 80-year-old person, that's not an abnormal amount of androgenetic alopecia. It sort of just depends on what's compared to that person's normal. So whether or not it's an explanation for their hair loss is a little bit more complex than simply saying they do or do not have changes of androgenetic alopecia. Again, the miniaturized hair. So when we talk about telogen effluvium, what we're thinking about in a ratio is an increased ratio from normal, which we said was normally 85% anagen and about 15% catagen telogen. You might increase to like 20% catagen telogen or 30% catagen telogen and down to 70% anagen, but it'll always be less than 50%, which is why people don't go bald, right, with telogen effluvium. So, and then chronically, if it's going on a very long time, you can get miniaturization. So sometimes the increase is very subtle and you'll get kind of wishy-washy, could be telogen effluvium answers. But you know, if you're sitting comfortably at like a 30%, you can say with a fair amount of confidence that you're probably looking at telogen effluvium. So this person, if you count all the number of follicles, you know, the ones I have in the screen is like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24 maybe. And then we have 1, 2, 3, 4, 5, 6, 7. We have about 7 telogen / catagen hairs that we can see from low power, right? We're starting to see that little kind of starbursty look in the middle, or this wiggly hair around the side. So 7 out of 24, you know, you're getting close to 30%. And that is increased from the 15%, right? So this person probably has telogen effluvium. In contrast, when we talk about alopecia areata and trichotillomania, you have a much higher ratio of catagen telogen hairs to anagen. It's greater than 50%. It can even approach 100%. You're not always going to see those peribulbar lymphocytes. You're lucky if you do, but you don't always. And so it's often just this significantly increased ratio that's going to tell you that you're thinking about alopecia areata. You can see very similar findings in psoriatic alopecia and syphilitic alopecia, but you might see changes in the epidermis that resemble those diseases, or even like shriveled sebaceous glands and things like that if you're more advanced. Okay, so this is an example of alopecia areata. Look at the number of telogen hairs. Look how skinny, this is a bulb, right? That horseshoe area, see how thin that horseshoe area is? That was a finding we saw in a telogen hair that went up the escalator. And then here, this is up higher in the follicle, and see they're all in telogen. This is almost 100%, if not 100% in telogen. You see this, it's gonna be alopecia areata or trichotillomania most commonly, unless they have syphilis or psoriasis to think about, okay? Here's up closer, here's your little skinny horseshoes, here's your little squiggly things inside the fibrous capsule of the follicle. And this is a vertical section of the same process. So now you look, and you have a lot of these streamers, right? The little streamers down below the follicle, that's the elevator that they go up and down. And they're mostly shriveled and high because they're almost all in telogen. Now this one does have peribulbar lymphocytes. There's a little bit of inflammation, but the rest of it you don't have. You just have this ratio. In this particular one, you can tell from a vertical section that you have alopecia areata even without the horizontal section, just because it's so striking how everything's in the same stage of evolution. All right, up close, see how shriveled it is, going up the elevator. All right, so trichotillomania, like I said, is about the same looking process, except what you have here, if you're lucky, is you'll see some obvious trichomalacia. So a little bit of this, you know, these like pigment casts that are left over from the hair being yanked out. It looks a lot like pressure-induced alopecia or anything else that can make, you know, your hair suddenly come out. So here we go. You can't tell so obviously here that you have a lot of hairs in catagen and telogen, because, you know, this is probably telogen, this is probably telogen, this is probably catagen. We can probably see that there's like increased necrotic cells if we zoomed in. Same here, and here's another telogen, but here's a nice pigmented cast for you, right? Here's another pigment cast. This is trichomalacia. It's the pigment that's left behind when the hair gets yanked out. It's going to be kind of similar findings in an acute traction alopecia also, if you think about it, because acute traction kind of mirrors trichotillomania, where you kind of yank the hairs out. Here's an example of another area where, see, you look and you see these little necrotic cells. These little necrotic cells, these are all catagen, okay? They're all in catagen, high ratio pigment casts. This is trichotillomania. Here is a vertical section. You see how all of your hairs are in this kind of telogen phase. You've got a lot of pigment in them. You can see that pigment in alopecia areata too. But when you go up to the epidermis, that's when you're going to start seeing your trichomalacia. Okay, there's your pigment casts. All right, so that is non-scarring alopecia. And the take-home message is that you should understand and be able to identify what a catagen and a telogen hair looks like, this little process of it going up and down the elevator, and how the ratios are what matters most in making those diagnoses, and that's why horizontal sections are preferred, because they're the only thing that can really give you a ratio, though you can make the diagnosis often on vertical sections. All right, so scarring alopecia. I like to divide scarring alopecia into two different sections. There's the scarring alopecias where you have decreased numbers of hair follicles, but not like a true scar. And then there's true scarring alopecias where you make like a real scar. If you think about these alopecias where you have decreased follicles like LPP or CCCA, when you look at the scalp, it looks very smooth, right? The skin does not look like you have a true scar there. It's just smooth because you have an absence of follicular ostia. And that's an important distinction, because you do not have a real scar in these cases. That little elevator that the hair goes up and down gets knocked out and the hair is gone. But you do not have scar that extends between the follicles. All right, so Lichen planopilaris. Lichen planopilaris is lichenoid, similar to LP, except the inflammation is in the follicle, but it's confined to the upper third of the follicle. And if you remember what's in the upper third of the follicle, that's where your bulge is, okay? So the inflammation is kind of hovering around your isthmus area, I'd like to say. And it affects the bulge where your stem cells are. And that's why you get a scarring process, because you've knocked out your ability to make a new hair follicle. In contrast, you see almost just as much inflammation in alopecia areata, but the inflammation there is confined to the bulb, the bottom blue part of the follicle. And therefore you don't see scarring, because that's not where you manufacture a new follicle from. Your bulge is still intact, okay? So this is a horizontal section of LPP. And what you see right away from here is that you have less follicles than you're supposed to have. So there are areas of missing follicles on this section. And when you go in closer, you also see these areas of fibrosis around some of these follicles and a lot of lymphocytic inflammation. When you go even closer, you'll see some necrotic cells in the follicle. And really what this indicates, how this starts, is that your lichenoid inflammation abuts your epithelium just like it does in other lichenoid conditions of the epidermis. But with time, you get these rings of fibrosis and they push the inflammation outward. So now your inflammation's hovering around here, and it's not all right here the way you would expect for a regular lichenoid condition. But over time, it's going to fibrose and fibrose and fibrose until it scars away your little follicular tract and your follicle no longer forms, okay? Here's a vertical section where you can see that the inflammation really only hovers right around this area, right around this area. You do not have inflammation tracking down around the bottom of the follicle. And here, if you can see, there's a slight color change. You are missing a follicle here. And this is evidence of scarring alopecia from vertical section. Although sometimes it's hard to tell if you're just in an area where a follicle, if you cut one section in deeper, you're going to see the edge of a follicle coming in, which is why it can be challenging. But it's nicely illustrated in a vertical section where your inflammation is. Okay, so here's your perifollicular fibrosis, your lichenoid inflammation that got pushed out a little bit, and here's your missing follicle with a little bit of fibrosis right in the follicular area. So how does discoid lupus erythematosus look different? This, obviously there's a fair amount of overlap and these are on the differential for each other. But one thing that I like to see is that the perifollicular inflammation goes around the entire follicle. It's not confined to the upper third the way LPP is. And you might have some interface at the epidermis that looks more striking for a collagen vascular disease than, say, lichen planus. So here you can see you have your superficial and deep perivascular, perifollicular inflammatory cell infiltrate. And you can see even in the lower parts of the follicle, your inflammation sort of goes all the way around. It doesn't only favor the upper third. And then if you go in close, you can see a little bit of your thickened basement membrane, a little bit of this lymphocytic dust that I alluded to, and the interface, which is your evidence of your chronic cutaneous lupus erythematosus. This is follicular plugging, which is nothing more exciting than compact keratin, which is on the epidermis, but also involves the follicles, okay? And you see here your inflammation tracks all the way around. If you do a mucin stain or if your lab has really good hematoxylin, you'll see mucin in the dermis and deep dermis as well, which can help you distinguish. Now see, in the follicle, you got your inflammation all the way down around it on the bottom. Here's another DLE. See a lot of pigment dropout because an interface, remember, shakes the pigment out from the basal layer of the epidermis and knocks it into the superficial dermis. And here's your perifollicular inflammation, kind of involving the entire follicle, okay? And then if you can see really, really closely, you'll notice that there's mucin throughout this dermis and an interface with a thickened basement membrane. All right. Now, how does CCCA and chronic traction look differently? Well, they have some inflammation, but they don't have such patterned inflammation like you see with LPP and DLE. You might see some nonspecific perivascular and perifollicular lymphocytic infiltrate, but not necessarily lichenoid. And mostly you'll just eventually get fibrosis or lose the follicle. When we get to an end stage of scarring alopecia, which is also known as pseudopelade, which is not like an actual condition, it's just a name for this end stage, this is the differential, and we can't actually distinguish between them if there's no more inflammation. So you just have to kind of give the whole thing. But what's important is if you look, you see all these little holes where there used to be follicles. That's where there's like a little bit of extra fibrosis where that stela was, but no more follicle. But in between the follicles, the collagen is okay. You don't actually have a real scar forming. All right, so this is an end stage. We obviously have no more follicles left and no more inflammation. So it's hard for me to tell you what caused it, but the differential is those scarring alopecias that don't cause real scars, okay? Just cause loss of follicles. Here's an up close in case you couldn't see how you're missing these follicles here. Okay. All right, so now we're gonna move on to slightly juicier scarring alopecias where there's so much damage in the area that you're actually causing a real scar. And so we have all these conditions, and sometimes people aren't actually understanding that the differences between them are, sometimes easier to appreciate under the microscope than understanding them clinically. So folliculitis decalvans. Folliculitis decalvans, for all intents and purposes, is a suppurative folliculitis. So what does that mean? That means there's a lot of neutrophils in the follicle, and it's probably bacteria-based, like a staph kind of based suppurative folliculitis. And it causes a lot of scarring between the follicles. Acne keloidalis can look very similar if you're in the stage where the follicle's been destroyed And now the hair shaft is exposed to the dermis, which remember is then foreign material, and then your body mounts an inflammatory response. So that inflammation can look similar, though usually it begins more lymphocytic the way acne does, as opposed to very suppurative the way folliculitis does. And we'll kind of go over what those, we'll review the differences between those in the next section. All right, so here was a follicle, here was a follicle. Now you see this dense, suppurative, and somewhat granulomatous inflammation. And so this was destroyed by something. The follicle was destroyed, and now you've mounted a major inflammatory response. And then if you look here in the dermis, you're going to see a lot of fibrosis and some plasma cells because it's been going on chronically for a long time. And that's your actual scar. So here's up close, pool of pus surrounded by histiocytes and lymphocytes and plasma cells, and then your scar where a follicle once was. And here's your scar, your fibrosis, your increased collagen, increased fibroblasts, squishing your blood vessels, plasma cells. Okay, here's another example. Here's a follicle, and it's very inflammatory, and it's not lichenoid with only lymphocytes the way LPP is. It is neutrophils in the follicle, okay? You might even be able to see staph with a Gram stain in the follicle, and then the follicle is destroyed, and then it'll get very inflammatory. And as it's destroyed, see, and your hair shaft is exposed, your body's gonna mount an inflammatory response to kind of close it up, and you're gonna get all sorts of scarring in between, true scar, okay? That's why folliculitis decalvans, you see real scars in it. And certainly, acne keloidalis nuchae also, you see these hypertrophic scars. They're not actually keloids, they're hypertrophic scars as a result of all the inflammation that's happening. Dissecting cellulitis, however, is different in that it doesn't start as a suppurative folliculitis so much up in that superior portion of the follicle, but it's this dense suppurative and granulomatous inflammation that's deeper below the follicles, which is why it can travel and cause sinus tracts deep to the follicles. So this is actually a case of just like a ruptured cyst, but I use it because I couldn't find one of dissecting cellulitis in my collection right now. And it just illustrates the same point. People with dissecting cellulitis, similar to the people with other things in the follicular occlusion triad, they have a problem with producing too much inflammation and shutting down that inflammation. So you get overproduction of this granulation tissue, and the process is very deep, all the way down here below the follicles, and then it slides around side to side, and you can get this very boggy look beneath almost normal appearing skin in areas, and that is dissecting cellulitis. Okay, see, below the level of the follicles, you can see it's a little bit fibrotic. Here's granulomas with your giant cells, mixed inflammation. All right, so this is our follicular occlusion triad, which I view less as a follicular occlusion problem and more of just an inflammation problem. These patients produce too much inflammation and they don't effectively shut it down. And so hidradenitis, pyelonephrosis, dissecting cellulitis, nodulocystic acne, you can have very similar findings. First, it might be very suppurative and granulomatous, but later you're just going to see significant overproduction of granulation tissue, and all that chronic inflammation might make sinus tracts from the epithelium, or you might travel, side to side, laterally, along the vagalia, like you might see with dissecting cellulitis, deep to the follicles. Here is a case of a pilonidal sinus. So your epithelium is growing downward, and actually, sometimes it's follicles, but sometimes it's just a sinus tract coming down. And all of this, you see, it's very pale. That's all edema. Edema, blood vessels, mixed inflammation, just tons and tons of granulation tissue. And you have a lot of neutrophils. You might have a lot of histiocytes in some areas because this inflammation destroyed the follicles, and the inflammation just keeps going and going and going and going and driving itself. All right. So now let's talk about some basics. We talk about acne vulgaris, we talk about folliculitis, and we talk about rosacea. And these actually look different under the microscope, and they are different terms. So I realized over the years that not all my residents understood the differences between acne and folliculitis. Okay, so what is acne? Why do we use retinoids for acne? Well, acne starts with a comedone. So you have a dilated follicle that's filled with keratin. And if you look in here closer, which we will do in a second, there's sebaceous material, okay? You have sebum, keratin, and then a bunch of bacteria. The P. acnes bacteria that may or may not be pathogenic, but it's along for the ride. Surrounding your comedone, you just have a little bit of a lymphocytic infiltrate, okay? And then should you rupture your comedone, either traumatically because you squeezed it, or, you know, just for whatever reason, if this ruptures, then you're going to get a very robust inflammatory response. At that point, it can become suppurative, but that's because your body's reacting to this foreign material that's normally supposed to be contained within this epithelium that opens to the outside, okay? Acne vulgaris. So up close, you can see the sebaceous material makes it a little bit kind of bubbly inside your keratin, right? You have a little extra keratin, you have some bacteria, hair shaft, dilated follicle, lymphocytic inflammation. Comedone, acne vulgaris. This is not a great picture, but the best one I could find. A follicle and neutrophils, okay? Normally you'll just have a follicle and it's packed with neutrophils. The most common cause of suppurative folliculitis, which is what this is, as you can see, there's no comedone, right? It's just neutrophils in the follicle. The most common cause of suppurative folliculitis is staph. It's bacterial folliculitis. You can also have other forms of suppurative folliculitis, like a sterile folliculitis that we see with steroids, right? You take corticosteroids, they don't get acne vulgaris, they get a sterile suppurative folliculitis. Or you can have suppurative folliculitis with, say, pityrosporum or other things. But mostly we're talking about staph, okay? This is what rosacea looks like. Rosacea, on the other hand, you see a little bit of sun-damaged skin. You see dilated blood vessels. See how dilated these blood vessels are? Perivascular inflammation and perifollicular inflammation. And this perifollicular inflammation can become granulomatous. This is what rosacea looks like. Again, no comedone and no suppurative folliculitis, okay? Perivascular, dilated vessels, perifollicular, plus or minus granulomatous, okay? Chronic, see all these plasma cells, little speckly faced nucleus off to the side, lots of plasma cells, been going on a long time, dilated blood vessels, etc. This is just an example of a folliculitis due to pityrosporum, okay? Sometimes we see that if it's in a very like seborrheic distribution, say upper chest, upper back, you know, maybe these are just along for the ride and they're not pathogenic, or if they're not responding to your benzoyl peroxide, and I see a lot of pityrosporum, I'll tell you that I see it in the follicle, and maybe then, you know, a Nizoral shampoo will do better for this patient. Okay. What's follicular mucinosis? Follicular mucinosis is when you see increased mucin within the follicle, and there's usually a lot of lymphocytes accompanying it. When we see this in young patients, it's usually an idiopathic condition. However, there is this association with mycosis fungoides, so it's not a bad idea to do gene rearrangements if that is a clinical possibility. From low power, you can see inside this follicle, we have this big pools of mucin. Now you can have idiopathic follicular mucinosis and MF-associated follicular mucinosis, but you could also have secondary follicular mucinosis. For example, if you have, you know, folliculitis or Meioki's or something else, you can have mucin pool in your follicles. But when you have this much mucin, this is usually like a true follicular mucinosis. And as you can see, there's a lot of lymphocytes around, and they may or may not be in the follicles. And so it's fairly subjective whether you think that this could be MF, even if you do all the stains. If it's one little area and it's a kid, I probably would just follow it. But, you know, if they have a fairly extensive involvement, it's probably a good idea to do gene rearrangement studies to make sure you're not missing mycosis fungoides. Here's an up close. This one has a lot of eosinophils. Also, you know, a big bug bite in the area causing a lot of edema. You can also get mucin in the follicle, but this one's pretty cleanly in the follicle. So this is follicular mucinosis. Okay, and that is it for alopecia and follicular disorders.